And so without further ado, I'd like to give a warm welcome to our speaker for today, Dr. Joanne Urban. Dr. Urban is a clinical pharmacist with over 20 years of clinical experience in infectious diseases and HIV pharmacotherapy. She has been a faculty member of the AIDS Education and Training Center in Florida since 1998, serving as co-editor of several treatment guideline resources and providing training and education to healthcare providers on a variety of HIV-related topics. She provides clinical pharmacy services at rural HIV clinics in the North Central region of Florida. And so with that, Joanne, I'm going to hand it over to you.
All right, thank you so much, Sally, and welcome everyone to today's webinar. We're going to be discussing antiretroviral therapy and keys to success. First, I need to disclose that I do have a financial relationship with respect to a company, Bristol Myers Squibb. My spouse is employed. He does not do anything related to HIV medications for the company, but the slide set has been peer reviewed to ensure there are no conflicts of interest represented. My objectives are listed on this slide, and hopefully you had a chance to review them before deciding to sign up for the webinar. And we'll get started by going over the items in the first objective, where we'll first discuss initial antiretroviral therapy, or ART, options according to the most recent Department of Health and Human Services, or DHHS, guidelines for the use of antiretroviral agents in adults and adolescents with HIV. So the treatment guidelines are updated as new drugs are approved and as new information becomes available. So the frequency just kind of depends on what information or new drugs are approved. So these guidelines were most recently updated in February of this year. And unless otherwise noted, the information I've included in my presentation has been adapted from these guidelines. You can access these guidelines at the website listed here, as well as a lot of other guidelines related to the management of patients with HIV infection. So if you're not familiar with this website, is here for you, and I suggest that you go to that website for a variety of treatment guidelines that are available. So first, let's review the recommended initial regimens for most people living with HIV. Now, initial regimens means just like it sounds, it's an initial regimen for patients who have never been on antiretroviral therapy before, and that's what we're focusing on during this session. If patients have been on antiretroviral therapy before, we take into account the prior regimens they've been on, any resistance that may be available, and reasons for changing regimens in designing a new regimen for a patient, but that's not within the scope of this presentation. So the initial regimen options recommended for most people include an INSTI, which is an integrase strand transfer inhibitor, excuse me, with either 2 nucleoside reverse transcriptase inhibitors, or on the next slide, there's an option that has 1 NRTI. So all of the options that are listed here are available in once-a-day options. And the first 2 regimen options that are listed here are available as single tablet regimens. That's the bictegravir, tenofovir, alafenamide with emtricitabine, and the dolutegravir with abacavir and lamivudine. You may know these as more familiar names as Biktarvy for the first one and Triumeq for the second. It's important to remember that we would only use the abacavir option if the patient is HLA-B5701 negative. This is a marker for the patient having a risk for having a hypersensitivity or a very serious allergy to abacavir. If a patient tests positive for HLA-B5701, we would never use an abacavir containing regimen. And we also want to make sure that this is notated as an allergy, both within their medical record and with any pharmacies that the patient uses. Also, we would not use this option in patients who have hepatitis B virus co-infection. The other options listed are not single tablet regimen options, but are available in once-a-day options. Dolutegravir with tenofovir combined with either emtricitabine or lamivudine, and raltegravir with either tenofovir and either emtricitabine or lamivudine. Raltegravir has a once-a-day formulation available, which is Icentris HD, or a twice-a-day formulation, which is Icentris. Now, the guidelines don't say which form of tenofovir is preferred over another. There are 2 forms of tenofovir that are available, and we'll discuss those in a little bit more detail. These are tenofovir alafenamide, which is TAF, or tenofovir disoproxil fumarate, which is TDF. And then usually the choice between either emtricitabine or lamivudine is really going to depend on the co-formulation that's available or that's going to be used. Another recommended option, initial option for most people with HIV includes the INSTI dolutegravir with lamivudine. You may know this as the brand name Dovato. This should only be used if patients have an HIV viral load of less than 500,000. They don't have hepatitis B virus co-infection, and they have genotype results showing no reverse transcriptase resistance. For these reasons, you're generally not going to see this medication or regimen option used in something called a rapid start or test and treat program, which is becoming more widely available. Throughout the state of Florida, at most Department of Health clinics, patients can get started on antiretroviral either the same day or within a few days of being diagnosed with HIV infection. And in this case, the baseline labs generally would not be available. So this would not be an option that would be used in the rapid start programs usually. So there are a variety of other initial regimen options that can be considered. And we sometimes do use some of these other options depending on the patient's clinical situation and comorbid conditions. So these options include the INSTI elvitegravir with the boosting agent cobicostat with 2 NRTIs. It's available with tenofovir alafenamide, which is Genvoya, or tenofovir disoproxil fumarate, which is Stribild, with emtricitabine. We also have boosted protease inhibitor options with 2 NRTIs. And these options include boosted darunavir or boosted atazanavir with tenofovir and emtricitabine or lamivudine, or there's an option with the boosted darunavir with abacavir and lamivudine. Again, abacavir only if HLA B5701 negative and no hepatitis B co-infection. So as you can see, all of these options have a booster agent, cobicostat or ritonavir. Those drugs are specifically included in the regimen to boost or increase the level of the INSTI or the protease inhibitor in the regimen. And I think this is one of the primary reasons why these are no longer listed as the recommended options for most patients, because we have to really take into account a lot more with respect to drug-drug interactions, because there's going to be a lot more potential drug-drug interactions if you have a boosting agent. Some other initial regimen options can include a non-nucleoside reverse transcriptase inhibitor, or NNRTI, with 2 NRTIs. There's doravirine, efavirenz, or rilpivirine. All of these do have single tablet regimen options available. For doravirine, there is Delstrigo, which has the TDF form of tenofovir with lamivudine. For efavirenz, there's a tripla, which has the TDF form of tenofovir with emtricitabine, and then Simfi has the TDF form of tenofovir with lamivudine. For rilpivirine, there are 2 oral formulations available, one with TDF, which is Complera, and one with TAF, which is Odefsey. With rilpivirine, it's important to remember that we should avoid this regimen option in patients who have a HIV RNA we should only use it if patients have an HIV RNA of less than 100,000. So avoid if it's greater than 100,000, and avoid if the patient has a CD4 count less than 200. So only use it greater than 200. So let's discuss in a little bit more detail some of the differences between TAF and TDF. So both TAF and TDF are what we call prodrugs. They're prodrugs of the active drug tenofovir. So these drugs are converted to the active tenofovir after they're in the body, after they're absorbed. So with TDF, this drug has a much shorter plasma half-life, and there are much higher levels of tenofovir that are able to be taken up by renal and bone cells, leading to more potential renal and bone toxicities. With TAF, there's a much longer plasma half-life and greater plasma stability, and there's a much lower dose that is needed to get the tenofovir to the active site to inhibit the viral replication within the lymphocyte. So as such, there's also less of the tenofovir available to be picked up by the kidney and the bone cells. So there's less renal and bone toxicities with tenofovir alafenamide or TAF. So just to summarize some of the similarities and differences between TAF and TDF here. So what about use for hepatitis B? Both of these drugs can be used for patients who have hepatitis B co-infection, and we'll discuss briefly hepatitis B co-infection in a patient case. Both of these can be used in a regimen for pre-exposure prophylaxis or PrEP. The TAF FTC or Descovy is approved only for use in PrEP in men or transgender women who have sex with men, though. In pregnancy, both of these can be used in women who are pregnant or trying to conceive. The perinatal guidelines now list the TAF as an alternative NRTI in pregnant women or those trying to conceive. In the studies, there's been increased lipids seen with TAF, higher bad cholesterol or LDL, higher good cholesterol, HDL, and also higher triglycerides. However, there was no difference in the total cholesterol to HDL ratio, which is a marker for cardiovascular disease risk. So really the clinical significance of this increase in the cholesterol or increased lipids is not known. Again, the TAF formulation has less renal and bone potential effects, less renal and bone toxicities. However, we are now seeing it's been increasingly recognized that TAF has been associated with more weight gain compared to TDF. And this is more common in women and Black or Hispanic patients. So what about the use of these drugs in patients with renal dysfunction and those on hemodialysis? So the TAF formulation specifically can be used if patients have a creatinine clearance of less than 15 if they're on hemodialysis. If the creatinine clearance is less than 15 and they're not on hemodialysis, it's not recommended. So anything higher than 15, the TAF can be used, less than 15 if they're on hemodialysis. However, I will point out for both TAF and TDF, the recommendations vary depending on the co-formulation that's used. So I'll refer you to the table that's in the guidelines for renal and hepatic dosing, where you can see the specific recommendations depending on the co-formulation that's used. For TDF, if patients have a creatinine clearance between 30 and 49, it can be dosed every other day. If they have a creatinine clearance between 10 and 29, it can be dosed twice a week. There's no recommendation regarding dosing in patients who have a creatinine clearance less than 10 if they're not on hemodialysis. And if the patient's on hemodialysis, then it can be dosed every 7 days. Okay, so let's review a patient case, and in a moment you'll see a polling question come up where you'll have an opportunity to select your option for this case. So this patient, Ricky, is a 28-year-old man who was recently discharged from the hospital where he was diagnosed with HIV and AIDS and disseminated Mycobacterium avium complex infection, or MAC. And he comes to the clinic to initiate antiretroviral therapy. He states he has no preference with respect to food requirements or the need for a single tablet regimen, but would prefer a once-a-day regimen option. He did have baseline labs available, including a genotype which was pan-sensitive. This means that there was no resistance mutations or significant resistance mutations detected. His liver function was within normal limits, as AST and ALT were within normal limits. His kidney function with his eGFR was within normal limits. And his viral load was 182,000, and his CD4 count was 43, as we might expect if someone's diagnosed with disseminated Mycobacterium infection. They usually have a pretty low CD4 count. So the medications he was prescribed and taking include rifabutin, azithromycin, and ethambutol for treatment of the MAC infection, and then also trimethoprim sulfamethoxazole for prevention of specific opportunistic infections such as PCP or PJP pneumonia and toxoplasmosis that he's at risk for with having this CD4 count of 43. So why is a TAF-containing regimen not recommended for Ricky? Is this because TAF may not be as effective as TDF in patients with high viral load? Due to drug-drug interactions, TAF levels would be expected to be increased. Option C, due to drug-drug interactions, TAF levels expected to be decreased. Or I'm not sure, I thought TAF could be used in all patients. So remember, this patient had a viral load of about 180,000. He's on treatment for MAC. He's on rifabutin, ethambutol, azithromycin. He's also on trimethoprim, sulfamethoxazole. So you should see the polling question here where you can select what you think is the reason. I've already told you TAF would not be recommended for him, but why do you think that's the case? Okay, I think we can go ahead and close the poll and see what the options are here. So we have it kind of all over the board as far as the selections here. By a small margin, most people selected TAF may not be as effective because the patient has a high viral load. So this is good for us to review this. Okay, so the reason is TAF levels may be decreased, and that is why we would not use a TAF-containing regimen in this patient. So drugs that are strong P-glycoprotein or PGP inducers are expected to decrease TAF concentration. So this includes the rifamycin, such as rifampin and rifabutin, St. John's wort, which is an herbal supplement patients sometimes take for depression or mood. Carbamazepine and oxcarbazepine are anti-seizure medications, but these are pretty more commonly used today as mood stabilizers. And then the anti-seizure medications, phenytoin and phenobarbital. So we do have to worry about some additional drug interactions with TAF compared to TDF. Okay, well, let's get started with the next objective, where we will list the factors involved in selecting initial antiretroviral therapy regimen for a patient. So there are a lot of different factors that come into play when selecting an option for a patient. It's important to remember that for most patients, there are multiple regimen options that are going to be appropriate clinically for that patient based on various factors. So when we are starting a regimen on a patient, we never go into the room and say, this is the medication that you should start, this is how you take it, this is when you take it, this is what to expect. That is not the conversation we have. We are usually going in there with multiple options. Depending on the patient's conditions or comorbid conditions, et cetera, there may be less options for some patients than others, but the vast majority of the time, there are multiple options that we discuss with the patient, and the patient's actively involved in determining what is the best option for them. So some of the clinical things that we look at, viral load count and viral load and C4 cell count. As I mentioned, certain regimens are going to be avoided with high viral loads or low CD4 cell counts. HIV resistance test results and HLA-B5701 status, if we're considering a bacavir, and then also comorbid conditions such as hepatitis B co-infection. But again, I remember that I said in certain circumstances, if patients are starting medications through a rapid start or test and treat program, this information is not going to be available. So certain regimens are going to be chosen because we don't have this information available. Also, we look at other co-infections as well. The patient's pregnancy, whether they're pregnant or they have pregnancy potential adverse effects of the medication, potential drug-drug interactions, patient preference, and also access to the medications and costs. And we'll discuss some of these in a little bit more detail. So for the comorbid conditions, we're looking at things like cardiovascular disease, hyperlipidemia, obesity, renal disease, osteoporosis or decreased bone density, and psychiatric illness that may impact our selection. For co-infections, we would be considering the hepatitis C virus co-infection status, primarily because if we are treating the hepatitis C infection, that could have some drug-drug interactions between the hep C agents and the antiretrovirals. Hepatitis B co-infection, and as well as tuberculosis, just to name a few examples. So some of the regimen and drug factors, again, possible side effects and drug-drug interactions. We also look at the convenience with respect to the pill burden, dosing frequency, and food requirements. And also the regimen's genetic barrier to resistance, which means how easy is it for the virus to become resistant to the medicines in the event of missed doses. Now, these two factors, a lot of these factors already have come into play with respect to what the guidelines recommend as the recommended options for most patients. But again, we're considering a lot of different options for patients depending on their particular situation. And then cost can be an issue. If the patient's insurance company only has certain antiretroviral medications available, then we may have to select certain drugs, or that may limit the drugs that we may consider for a patient just due to the insurance coverage or the insurance formulary. So it's extremely important that we talk to patients about their preferences and any potential barriers to adherence before starting or selecting the antiretroviral regimen for the patient. So what is the patient's typical day like? Dosing frequency, pill burden, food requirements, size of the pills, etc. We'll ask the patient, what's the most convenient time to take the medication? Sometimes patients have a more hectic schedule in the morning or the afternoon, and we work with the patient to determine the best time. Also, how will the schedule differ on the weekends, and what will happen if they travel? Most insurance companies do allow for a 90-day supply of medications to be filled. Even if they don't allow for it regularly, an exception can usually be granted in the case where the patient's going to travel. And then again, how will the cost of the medications impact access? Okay, so we're going to discuss some patient case scenarios and selecting initial regimens, taking into account some of these factors we've just discussed. Cynthia is a 28-year-old woman who was recently diagnosed with HIV, who presents to the clinic to start antiretroviral therapy through a rapid start program. As such, the baseline labs are not available and they're being drawn at the clinic visit. She's been treated for chlamydia twice in the past. She's not married, never smoked, and does not drink. She has one child and is interested in having more, and her only birth control method is condoms. So what regimen would you choose for Cynthia? I've listed here the abbreviations for the antiretrovirals, which I had defined on the prior slides. And for simplicity, I will just list and mention these all as brand names for consistency. So option A is Biktarvy. Option B is Descovy with Prescovix. Option C is Descovy with Tivicay. And option D is Truvada with Tivicay. So what option might you choose for Cynthia, 28 years old, recently diagnosed? She's using condoms for birth control, and she's interested in having more kids. And it looks like most people have chosen Biktarvy in this situation. And there's really no wrong answer, I will tell you, in this situation. There's not really an answer here that would not be correct. But we will review the updates with respect to the INSTIs and the risk of neural tube defects. So a year or two ago, the guidelines were updated and came out with a warning regarding a small risk, increased risk of neural tube defects seen particularly with dolutegravir, and the guidelines stated it was not known if this was the effect. This was based on a study in Africa that showed this small increased risk. And over time, they've evaluated this data and information, and the guidelines recently have been updated to list dolutegravir as a preferred agent throughout pregnancy and in women trying to conceive. Because of the risk of the neural tube defects being so small, and the potential advantages of dolutegravir, including once daily dosing, it being well tolerated, and leading to rapid viral suppression. So the guidelines do stress the importance of patient counseling, though, and making an informed decision regarding this. And I refer you to the link here for additional information about this recommendation and in general for the use of antiretrovirals in the perinatal setting. Okay, this next patient, James, is a 23-year-old man recently diagnosed with HIV. He has a CD4 count of 482 and has a viral load of around 29,000 with no resistance detected. He has good kidney function, no issues with liver function, and he has no hepatitis B co-infection. In discussion with him, he states he would prefer a 1 pill once a day regimen and does not want a regimen that has to be taken with food. So what regimen would you choose for James? Would you choose A, Dovato, B, Triumeq, C, Biktarvy, D, Odefsey, or E, Simtuza? And these are all single tablet regimens, since he said that he would prefer a single tablet regimen, and he wants a regimen that does not need to be taken with food, because he, like many of our patients, doesn't have a consistent and regular schedule as to when he eats. Okay, so we can go ahead and close the poll here. Most people for this had selected Biktarvy. So with this regimen, with this question, with the patient saying he does not want a medication that has to be taken with food, the two options here that we would avoid are Odefsey and Simtuza. Those need to be with food. Dovato, Triumeq, and Biktarvy do not need to be with food. So let's review the food requirements with respect to antiretroviral agents. So the medications most commonly used that need to be taken with food include the protease inhibitors, atazanavir and darunavir, as well as the INSTI elvitegravir. And it's important to point out the reason they need to be taken with food is to ensure adequate absorption. I find sometimes patients think they need to be taken with food because it might upset their stomach if they don't take it with food. While that may be true in some cases, the reason is to ensure adequate absorption. So we would like all patients to take this with food, even if they feel like it doesn't, upset their stomach. Now, rilpivirine, oral rilpivirine containing regimens, I need to now say, need to be taken with a full meal. So all of the drugs listed here are oral medications containing rilpivirine. They need to be taken with a full meal. Efavirenz containing regimen should be taken on an empty stomach. And this is because if efavirenz is taken with food, there's actually increased absorption and increased risk for side effects. Again, this is the food requirements with the agents that we are more commonly used today. Okay, let's move on to the next case. This is Alicia. She's a 58-year-old woman, recently diagnosed with HIV infection, who is being seen to initiate antiretroviral therapy. And she has no baseline resistance mutations detected, so she had baseline labs available. She has a CD4 count of 375 and a viral load of 10,502. Her estimated glomerular filtration rate is 58, showing that she does have some compromised renal function, and she has some slight elevations in her AST and ALT, or liver enzymes. Hepatitis screening is done and shows that she has hepatitis B co-infection. Her hepatitis B viral load was 1.2 million. And we often see very extremely high hepatitis B viral loads. It's actually more difficult to get the hepatitis B viral load under control than it could be to get the HIV viral load under control. She doesn't have hepatitis C infection, but she is not immune to hepatitis A. So we'll want to remember that it's going to be important to offer her the hepatitis A vaccine. So which regimen below would not be appropriate for Alicia? So she has hepatitis B co-infection. So what would not be appropriate to recommend for this patient? So option A is Dovato. Option B is Truvada with Tivicay. Option C is Biktarvy. Option D is Simtuza, or option E. All of the above are appropriate options for this patient who has hepatitis B co-infection. Okay, so most people did select the appropriate option here, which would be Dovato, because this regimen would not adequately treat patients for hepatitis B unless you had another hepatitis B agent that's prescribed separately. I should need to point out that caveat. So let's review what the recommended initial regimen options are for patients who have hepatitis B co-infection. So when patients have hepatitis B virus or HBV co-infection, it's really important to use 2 drugs that are active against hepatitis B and HIV. So this is tenofovir, either the TAF or the TDF formulation, with emtricitabine or lamivudine. And again, there's a variety of combination pills and also single tablet regimens that have these in them. It's important to remember that poor adherence or lapses in therapy in people with HBV can lead to very severe liver disease, including failure or death, because they can have a rapid reactivation of the hepatitis B infection. So it's extremely important. We don't want any patient with HIV, obviously, to go without their antiretroviral therapy, but it is extra important in patients who have hepatitis B co-infection that they do not have lapses in their therapy, because they could have significant issues related to the Hep B. And also, if we need to change their antiretroviral regimen for whatever reason, we need to remember that that patient has Hep B co-infection and make sure that that infection is adequately treated, whether it's with antiretrovirals that have Hep B activity or other agents that have Hep B activity when we're changing their antiretroviral regimen. Okay, so this next case is a patient, Jessica, who's a 32-year-old woman who was diagnosed with HIV infection in 2018. And she's been on a stable regimen of bictegravir, emtricitabine with tenofovir elafenamide, again, which is Biktarvy. Her viral load most recently was less than 20, and her CD4 count was 789. And she's on the following medications: omeprazole, ethinyl estradiol norgestimate, which is Sprintec, which is an oral contraceptive, and ferrous sulfate. Which medication is expected to interact with the Biktarvy? Is it omeprazole? Is it the ethinyl estradiol norgestimate? Is it the ferrous sulfate? Or none of the above? So take a moment to think about this and which concomitant medication this patient's taking that you might expect to have an interaction with the Biktarvy. Okay, so this was a good case discussion to include, I believe. Most people selected omeprazole. Actually, the correct answer here would be ferrous sulfate. And so let's review the drug interaction potentials with the INSTIs, including Biktarvy, with respect to some of these medications. Okay, so this chart is very busy, and this chart is available on our one of the resources I will show you at the end, which is a pocket card that summarizes some antiretroviral therapy information. And this, again, was adapted from the guidelines. So as far as our INSTI interactions, there are very few interactions with the INSTI. So that's why they're often a great option for most patients. However, there are some interactions we need to look out for. And it's particularly important because all of these things can be purchased over the counter. So we need to make sure we're always asking patients about what they take over the counter. And when we start a patient on an INSTI, we review these potential interactions. So with antacids that contain things like aluminum, magnesium, and calcium, as well as polyvalent cations. So any medications that contain polyvalent cations, such as multivitamins, certain supplements, sucralfate, there is a potential interaction where these cations can bind the INSTI. And so there are specific recommendations depending on the INSTI and which cation we're talking about. In general, you can take the INSTI at least 2 hours before medications containing these, or 6 hours after. I usually explain the 2 hours, take the INSTI 2 hours before, I think is easiest to remember, particularly if they're taking the INSTI in the morning, if they need Maalox, Tums, later in the day. If it's been at least 2 hours, great, no problem. If it's requiring the patient to take these more frequently, we need discuss that and discuss how to time things. Also, if patients are on like twice a day calcium supplement, we sit down with the patient and kind of, determine the timing. In some instances, for example, with the bictegravir and the dolutegravir, you can take calcium or iron at the same time with food. So that interaction can be overcome by that. But so the interaction is not due to acid reduction, it's due to the cation binding. And this is why we don't have an interaction with our H2 receptor blockers, such as famotidine and ranitidine, or our proton pump inhibitors, such as omeprazole and pantoprazole. And I find patients are often confused by this. So I think this is really important to review with our patients. Okay, so let's move on to our last objective, where we're going to identify resources to assist patients in maintaining access to antiretroviral therapy. Okay, this first patient is a patient named Bill, and he's 32 years old, has HIV infection, and he was seen at the clinic to restart antiretroviral therapy. He was previously well controlled on bictegravir, tenofovir, alafenamide, and tricidamine, again available as Biktarvy. He has private insurance through his job and was using a local pharmacy that told him his copay was $1,000. He did not have $1,000 to pay the copay, which he was basically told, your copay is $1,000, how would you like to pay? And he got extremely frustrated and he fell out of care for a year. We have patients similar to this that we've seen, and this happens, and we always try to we try as best we can to make sure we educate patients on what options are available, so this type of thing doesn't happen. But unfortunately, it does happen. Now, the next patient case is Stephen. He comes to the clinic to reestablish care. He had been previously well controlled. This is actually based on a patient of a different name that came to our clinic after being seen at another clinic for years and years. And he was on efavirenz, emtricitabine, tenofovir, disoproxil fumarate, the other name for that, Atripla, since 2009. He was extremely well controlled when he was last in care, viral load less than 20, CD4 count greater than 700. And he fell out of care. His copay used to be less than $10, but he said his copay then went up to over $900 a month. And he said he paid the copay when he could. And what I always cringe when I hear is he started taking the medication every other day to stretch it out because he couldn't afford the copay every month. And this client has Medicare, but no longer has the low income subsidy. And patients, at least in Florida, when patients have the low income subsidy, they get Medicaid along with the Medicare. And when I see that they have both Medicaid and Medicare, I'm pretty confident they're generally not going to have copay issues. The copays are going to be very low. They may have copay issues if they're on a lot of medications. But if patients only have Medicare, most patients are going to need some assistance because they will, over time, have some high copays. So you can put your answers to this in the chat box. What resources could have been utilized to assist Bill? Now remember, Bill had a private insurance plan through work and Stephen has Medicare. What resources could have been utilized to help them obtain their antiretroviral therapy and maintain access to their antiretroviral therapy? So go ahead and put your information in the chat box.
A lot of folks saying copay assist cards, copay assistance cards from the manufacturer, ADAP program, Ryan White ADAP program, patient assistance programs like from Gilead and ViiV, Ryan White assistance.
Great. Okay. All right, so let's review some of these options and resources that we have. Okay, so we have copay assistance programs, and hopefully you're familiar with those and are helping your patients access these programs. So there are pharmaceutical company programs, and I've listed the websites here for the most commonly used companies with respect to the medications we more commonly used. You can have a card available in your clinic that the patient can activate. And also you can go online, and I usually just go online and enroll the patient. If the patient's there, I print out the card for them right then and there. And I also save a copy and upload it to their electronic medical record in case somehow they lose it or the pharmacy loses it, what have you. It's important to note that those cards are drug specific. And of course, they have to be activated for the individual patient. They need to be renewed every year. Generally speaking, it usually covers about $7,500 of copay per year. And there are no income limitations for these programs that I'm aware of. But an important point is they cannot be used with federally funded insurance, such as Medicare, Medicaid, and TRICARE. So other options that don't have the limitation on use in patients with the federally funded insurance include Good Days and Patient Advocate Foundation. So we, as much as possible, use specialty pharmacies, whether they're mail order or local specialty pharmacies, that will assist us in assisting patients in making sure they know about these programs and are enrolled in these programs. Some patients, though, do not want medications delivered to their house, or in our rural areas, we don't have a local, quote, specialty pharmacy in the rural areas, and they use a local retail pharmacy. And unfortunately, most of them will just say, your copay is $500 or your copay is $250, cash, check, or charge, and leave it at that. And that is why we have to make sure we're letting patients know about these programs. And again, other resources that you guys did mention and list in the chat box. The ADAP program can usually help if the patient qualifies for copay assistance, and they may be able to access copay assistance through their Ryan White medical case management. And there may be other local resources available that you utilize for your patients. Okay, the next case is a patient named Anna. She's a 48-year-old woman who was seen in the clinic for follow-up of HIV, and she is well controlled on a regimen of emtricitabine, tenofovir, alafenamide with darunavir and cobicistat, which is Simtuza. And her viral load most recently was less than 20, and her CD4 count was over 1,000. She's been suffering from migraines, and her provider has prescribed a new medication since sumatriptan is no longer working for her. So she has no insurance. She's currently on ADAP, and this drug is not on the ADAP formulary for her. And she asked her Ryan White case manager for assistance in obtaining the medication since it's not on the formulary. So you find out the medication is called galcanezumab, which I may be pronouncing incorrectly because I'm definitely not an expert in the anti-migraine medications. The brand name is Emgality. And I can tell you anything that ends in MAB, which is a monoclonal antibody, is usually going to be very expensive. And as such, this medication is over $800 per month. So what are some medication resources, not copay specific resources, but medication resources? For this medication, most likely it's the resource utilized would be a pharmaceutical assistance program. And I usually access the website needymeds.org for the pharmaceutical assistance program applications and information. Another useful resource, though, is GoodRx, which provides discount cards for medications. The only thing I don't like about this, it's very drug and pharmacy specific. So if for some reason you have a patient that needs to try to access multiple medications through GoodRx, they're potentially going to be looking to get the best deals. You go to the website, you list the specific drug, you list the zip code of where you're looking, and it'll give you the price at several different pharmacies in the area. And then you print out a discount card that's specific to that medication in that pharmacy. So if someone is needing it for multiple medications, then they might be shopping around to multiple pharmacies, which I don't prefer that patients have to do. Also, Ryan White medical case management may be an option, but for medications that are extremely expensive, often that's not going to be an option, at least long term, of course, due to limited funding available and need to be helping as many patients as possible. And then you may be aware of other resources, area-specific resources that you might have in your area. So what about some adherence interventions to help patients stay on their therapy? Of course, we've talked about the copay assistance programs. Of course, patients can't take the medicine if they can't access it. Also, community resources to help patients with adherence. We have peer advocates in our area. We will talk to patients about what support they have, whether family or friends that can help them with their medications. Some patients just need someone to support them, be a cheerleader, so to speak, in helping them to stay on track with taking their meds. And other patients need additional help with just keeping track of what they're taking and how to take it. We recommend use of pill boxes. We have keychain pill holders. We recommend the use of alarms to try to remind patients of when to take their medications. We often will use specialty pharmacies, again, which are going to help patients in not only maintaining access to their medications, but they usually call the patients every month before delivering their medications and will let us know if they can't reach the patient. So we know that there may be a particular issue happening with that patient. We will use packaging such as bubble packs when available when patients are on complicated regimens or just need assistance with making sure that they took their dose, because sometimes it becomes so routine they don't remember, or you don't remember you took a medication. Okay, so I didn't discuss this in detail, but the guidelines were updated in February to include the recommendation regarding the injectable long-acting antiretroviral regimen, cabotegravir rilpivirine. And I didn't discuss this in detail because I was focusing more on the initial regimen options. The brand name for this is Cabenuva. This is approved as a once-a-month long-acting injection, particularly in patients that are already suppressed on a current oral antiretroviral regimen. And the recommendation is that they be suppressed for at least 3 months. The patient should not have any baseline resistance to either medication, have no prior virologic failures. They should not have active hepatitis B infection unless they're receiving other oral therapy to treat the hepatitis B. They should not be pregnant or planning to become pregnant, and not receiving medications with a significant drug interactions with the cabotegravir and rilpivirine. So this is a combination of an INSTI, cabotegravir, and an NNRTI, rilpivirine. Rilpivirine is already available. There's oral formulations of rilpivirine, and cabotegravir, this is a new INSTI. One thing to point out, since the rilpivirine is not being used orally here, we don't have the issue, of course, of having to take it with a full meal. And I didn't really discuss the rilpivirine interactions with acid-reducing agents, but the oral rilpivirine interacts with acid-reducing agents. You would not, of course, have that with the injectable. So this is an option, of course, can support adherence for many patients. We have a patient right now that we're working on getting started on this medication. She is someone who she takes her meds, she's suppressed, but it's a constant daily reminder of having HIV to have to take those meds every day. And I work primarily in rural areas, so I think one of the barriers for us with this is going to be patient transportation to get to the clinic because they do not have often reliable transportation. There's not public transportation available for most of the clinics where I work. So that's going to be a potential barrier there. But I think this is, really a great option to have this long-acting injectable available. And I think we're going to be seeing more of this in the future. Okay, so let's summarize the keys to success. So remember, regimens are selected based on a variety of factors to optimize chances for success. We need to consider patient preferences. And one thing that's really important, remember patient circumstances change over time. Anytime I see patients that have insurance, they're working, they have insurance through their job, they have no issues accessing their meds, that's great. But they need to know that if that changes, and think about it, that can change very frequently, they need to know that there's ways to access the medication. So regardless of what their current status is, make sure that they understand if something changes, they can call right away and we will help them maintain access. We need to assess any barriers to obtaining and taking medications in each and every visit. whether the pharmacy is not filling the prescriptions on time. If a pharmacy is providing a partial antiretroviral regimen, this is one of the reasons why we often would prefer a single tablet regimen, even if the patient doesn't, because especially if they're using a local pharmacy that might fill a partial regimen, if we have a single tablet option, we know that they're not going to get a partial regimen. We need to make sure patients can access their medications, whether they need meds shipped to them because they don't have transportation. Again, the copays we talked about. And then also addressing side effects and whether the patient's taking the medications regularly. I mentioned this resource and it's currently being updated, but hopefully it'll be updated soon and on our website where we review antiretrovirals in adults and adolescents and provide a lot of information regarding the antiretrovirals. And then also we have some medication information sheets available through the North Florida AETC site where we summarize some of the important points for all of the antiretrovirals, and there's a single sheet. I find this useful for educating new providers and case managers, but then of course also to provide as a resource to patients when they're started on medications. Okay, and with that, I know we have a few minutes for questions, so I welcome any questions that you all have, and I thank you all for your time and attention.
Great, thanks, Joanne. Let's dive into some of these questions. I'm not sure we'll be able to get through all of them today, but we'll do sort of a selection. Here's an interesting one. This person writes in, I have a patient who is being put on PrEP. His husband is living with HIV. The husband is on Biktarvy with abacavir. The patient is on Truvada with abacavir. This is the first time I have seen 3-drug PrEP. Is this normal?
So for one, I only work in the clinics where we're treating patients that actually have HIV. However, I'm relatively familiar with what is used for PrEP, and I've never seen someone on a 3-drug NRTI option for PrEP. I'm not at all familiar with using that.
Yeah, I did a quick search along the guidelines, and I'm not seeing something to recommend that either. Might bear further scrutiny.
Yes.
Let's see. We had someone write in earlier, and you addressed this a little bit, but I kind of want to add my own question, tack it onto this. Someone wrote in earlier, was curious about injectable cabotegravir, rilpivirine, and you sort of addressed that. So again, I kind of want to add my own question there, and it might be too early to tell since this is such a new regimen or newly approved regimen. I understand that some of the question about weight gain in ART is related to integrase inhibitors. So I'm wondering if there's a reason to be looking out for weight gain related to cabotegravir.
So I haven't seen the information about cabotegravir with respect to weight gain, but I would say that it's definitely something to consider because I think it's seen with most of the INSTIs, although some more associated with it than others. But I haven't seen that information as far as the specific data regarding the weight gain with cabotegravir.
Yeah, thank you. This person has a question. I think this goes back to one of the earlier poll questions related to patients who are pregnant or may become pregnant. This person wants to clarify, was the dolutegravir a better option for patients who are pregnant? Wanted to make sure they don't have that backwards.
So the dolutegravir is an option. So I think most of the options that I listed there could be considered for that patient. But the Biktarvy is not listed specifically as a preferred option because of less data available, but dolutegravir now is listed as a preferred option throughout pregnancy and women trying to conceive. We used to, and then also the TAF is considered an alternative NRTI. So when patients were trying to conceive, we in our clinic used to primarily switch them if they were on Biktarvy, say, or Descovy Tivicay, we would switch them to like Truvada and Icentris. We actually had a patient this past year where that was the case, and you know, at the time the guidelines were suggesting, to avoid dolutegravir in women trying to conceive, but then once they're pregnant, that it was okay. And we're like, well, she was having trouble doing the twice a day. And I was like, well, so basically today she's not pregnant, tomorrow she is pregnant, and we'd be okay to switch her to the dolutegravir. So we ended up switching her to dolutegravir before the guidelines changed to say trying to conceive, that is still now a preferred option. So it's just that the guidelines now have been updated to suggest that the dolutegravir can be a preferred option throughout pregnancy and trying to conceive. I hope that answered that question. Sorry.
Yeah, thank you. And then I see, while we're running up close to the time, I wonder if I can keep you just a minute longer for one more question. All right. Is there evidence of elevated HDL/LDL/triglycerides in Biktarvy, such as those discussed with Genvoya?
It's related primarily to the TAF component, so I think that is there. But again, with the increases in the cholesterol with respect to TAF, I think that we're not really sure how clinically significant that is, because again, there's an increase in the HDL as well. So the total cholesterol to HDL ratio, I believe in most of the studies, is unchanged. So we really don't know the clinical significance of that increase.
All right, perfect. And so I see there, there's been a lot of interest about this, talking about the subject. I'm seeing questions that we weren't able to get to today. Folks, I do want to let you go on time. So if there are burning questions that we weren't able to get to today, feel free to shoot us an email, contact the SEAETC, and we are always happy to provide that sort of technical assistance or answer any questions that you need answered. Be sure to tune in next week when we welcome Dr. Spiros Callums for a presentation updating us on HIV vaccine efforts. And with that, I think we can wrap it up for today. Thanks so much for attending, everybody. And a huge thanks to Dr. Urban. That was a really fantastic way to just sort of lay it all out, lay out a complicated subject.
Thank you, everyone.